Hi guys, today we're going to be talking about shin splints, and we're doing the second part of the question from Warren. Thanks again, Warren. Another friend of mine has started running again after 6 months off. He is struggling a bit with shin splints. How much running can he do to help him improve his fitness without the risk of overdoing it and causing more serious damage? What advice would you have for him? So this is a good question because running and shin splints go together very well. Now, depending on which study you read, sometimes they say that shin splints is actually the #1 running injury. It's usually in the top 3, and it's definitely there or thereabouts most of the time. It's definitely more common in new runners or in runners who've taken time off, and it really is running that's the thing that will provoke shin splints, not so much biking, swimming, that kind of stuff. It's the impact from running that'll provoke the shin splints. So we're going to talk through a little bit about what to do about shin splints. There's some practical advice for Warren's friend, but also I wanted to give some context by giving the sort of pathology or the theory of the pathology of shin splints so that the advice makes sense. Now, shin splints is a very difficult problem. Depending on what you read, it could go on from anywhere from a few months to up to a year. Some runners struggle for longer with shin splints than a year, but most commonly it is sort of time boxed to that kind of 1 year period. Now, again, it's more common in runners who have just got running or people who've had time off like Warren's friend and are getting back to it. The pathology, it's not quite nailed down 100% actually. We used to think that it was the muscles attaching to the shin bone. So they were particularly concerned with the soleus and the tibialis posterior muscle. And actually, I suppose I should clarify, what are we talking about here? Shin splints. That's a generic term for pain in the shin, usually brought on by running. And it hurts when you run or when you've been running, and it doesn't hurt if you're resting, right? So that's the behavior of shin splints. And for many years, it was believed that the connective tissue part of the muscle, so the muscle becomes a tendon just before it inserts into the bone, and the overlying fascia that is around that area just on the inside of the shin, so it's in, they say, the lower third of the tibia. The tibia is the shin bone, so if you go to the lower third, the third of the shin bone near the foot, and the medial side, medial is like the inside, it's like near the center. So another name for shin splints is medial tibial, right? So medial, inside, tibial, shin bone. Stress syndrome, meaning we don't know what it is. It seems to be related to stress. So medial tibial stress syndrome or shin splints works fine. I say shin splints. It is a little bit of a harsh sounding term, but it's the term that the general public use, and it's the easiest to sort of communicate. Now, I'll get back to what we think is going on now. Where those muscles, tibialis posterior, soleus, that kind of stuff attached to the back and the inside of the shin bone, we thought the attachment there was being irritated by the constant pulling of the running. So it was sort of tugging on the tendons where they attach to the bone, and it was believed that that's where the pain was coming from. And that was basically, how I used to explain it to people when I got out of university. That's how it was explained to me. And then that theory kind of went out of fashion with some research that looked at bone stress, looked at shin splints as more of a bone stress injury, and looked at bone scans and MRIs and things like that, looking at the actual tibial bone. And it's come back into fashion a little bit, so we're not quite sure which of the two it is. So if it's the bone stress injury side, that means, we've got this outer layer of bone. So right on the outside of the bone, there's a thin layer of almost like a kind of skin. It's not quite a fascia, it's not quite a skin, it's not quite a bone, it's this connective tissue layer. And that was Socks, if you could hear him. Hi Socks, he wants to go for a walk, so I'll have to be quick. There's this connective tissue layer on the outside of the tibia, and one of the proposed pathological explanations for shin splints is that periosteal layer becomes inflamed, becomes swollen. So what's happening as we're running, we're coming down and hitting the ground each time, and the tibia kind of bores outwards, right? So it bores laterally as you take the impact. And what that does, if you imagine like a bore, that you're pulling the string, so that the inside of the bore is being kind of is being kind of squashed, and the outside is being kind of stretched. And one of the theories is that the tibia, each time you're hitting the ground, is boring out a little bit, and the inside part of the tibia, the medial part where the pain develops, is being kind of squashed. And that if the impact being placed on the tibia is greater, and the stress being placed on that inside part of the tibia around the periosteum is greater than its ability to adapt to that impact, then you'll develop shin splints. So that's the other sort of competing theory. And that puts shin splints, or medial tibial stress syndrome, on a bone stress injury spectrum, going from everything from a normal reaction, meaning you go for a run and you experience that stress in your bones, and your bones say, hey, well, that was pretty intense, so I'm going to make the bone stronger so that next time you run, I can tolerate it. And that's just the normal adaptive response that is basically the training effect. And then that moves more into a slightly pathological area when the stress is increasing and the ability of the bone to adapt to that stress is not keeping up. Then we have what you call a stress reaction, and they can see this on bone scans and such, where they see that the periosteum is becoming a little inflamed, but it's not really any significant damage yet, but there is a reaction in the bone to the stress. So the sort of damage is slightly outweighing the repair. And at the other end of the spectrum, when things are all in alignment, the repair is outweighing the damage. And then at the far end, at the sort of bad end of the bone stress injury spectrum, the damage far outweighs the repair, and that's where you develop a stress fracture. And this is quite important, because if you think that if you think your friend has shin splints, then first thing is to get it checked, because it might not be, it might be something else. And one of the main things that it could be would be a stress fracture. Now, the way we would differentiate it is how we diagnose shin splints usually is the history. So it has to hurt when you're running or after you're running, and it doesn't really hurt the rest of the time. If it's hurting at rest, that's a bit of a warning sign. So that might indicate a stress fracture, or it might indicate another pathology like compartment syndrome or something like that. And I don't want to get into it too much, but if you don't have this, what we call mechanical pattern, where I run, the more I run, the more it hurts after I run, it doesn't hurt if I don't run, it doesn't hurt at rest. That's a mechanical pattern. That's probably medial tibial stress syndrome or shin splints. But if you have a pattern that is other than that, like it hurts at night, it hurts when I'm not running, if I run, it hurts for like 2 days afterwards, that kind of thing is more concerning and definitely needs to be checked urgently. And there is, in compartment syndrome, I mean, I can't imagine this is what's going on, because your friend would have already gone to the hospital. But if you've got progressively worsening shin pain, then you might have a developing compartment syndrome that needs emergency attention. So basically what's happening is the compartment at the front, I don't want to get into the pathology too much, but this syndrome of compartment syndrome is where the front compartment of the shin, which is surrounded by fascia, the pressure is increasing and increasing and increasing, and that can cause like nerve damage and other permanent damage to the tissues in that area. So it needs emergency medical attention. Now, that's probably not what's going on here, because this isn't how you would have described it. But that is something for anybody listening or watching this to watch out for. Progressively worsening shin pain, go to the hospital. And that means, it's not getting better with rest. It's not going away, it's actually getting worse. But let's put that all that horrible stuff to one side and say we're pretty confident that we're talking about shin splints, medial tibial stress syndrome, hurts when I run, doesn't hurt when I'm not running. And then, well, is it a connective tissue muscular issue, or is it a bone stress injury issue? Probably sometimes it's one or the other, or a bit of both. Medicine, I think, in the longer term will be able to tell us which it is, but for management, it doesn't really matter actually, because it won't change our management strategy depending on which of the two tissues is causing the pain, whether it's the bone or it's the connective tissue slash muscles. So in the show notes, I've included a video, an old video I recorded, and some links to blogs about shin splints. So if anyone wants a little bit more information on the pathology of shin splints and how it develops into a stress fracture, then check out the show notes for the episode, which will be in the description. Now, we want to make sure, okay, obviously it's not compartment syndrome. Is it shin splints or is it a stress fracture? Now, that's a very difficult thing to determine. I would certainly say you need the input of a qualified professional like a physiotherapist or something to help you decide. Now, one of the ways I would decide is to palpate, which means to press on the medial shin, medial tibia, which is the inside of the tibial bone, the shin bone, in the painful area. And what I want to see is a sort of long line of tenderness. So compared to higher up the shin, when you press there, it doesn't really hurt. Go down into the sort of lower third and it starts to hurt with the same amount of pressure. We would call that tenderness on palpation. And I want to see, a few centimeters of continuous similar amounts of tenderness on palpation. If I'm going through and I press on one bit and it's really, really, really sore, like that, this one point, that might be a stress fracture. So it's not a sort of uniform line of tenderness, it's a focal point of tenderness. Now that's not hugely diagnostically accurate, but if that is the case, then you definitely want to get it checked, because that might indicate a stress fracture, and that needs to be managed in the same way as we're going to manage the shin splints, but more conservatively. So you're going to be more cautious and you're going to approach things more slowly. But that being said, I have managed people with tibial stress fractures before, and stress fractures in the foot, and I've had one myself. I'm pretty sure I never actually got it diagnosed, because you can manage them in the same way as we're going to manage shin splints. You just expect the recovery period to be longer, and you have to be more gentle with them. They tend to be more reactive, more irritable, and a little bit more whiny and a bit more difficult to address. So that's the first part. We want to make sure that it is shin splints that we're dealing with. Now, how much running can he do to help him improve his fitness? Now, obviously I don't know the details, but I can give you some rules that I would use if your friend was in the clinic to help me make the decision about how much running is okay now. And the rules, well, they go like this. The first one is the easiest one, and it's the one I say all the time, and I'll probably say it in other episodes, and you may have heard it before, and it's the green, orange, and red pain response. Now, if you imagine a pain scale of 1 to 10, right? 4 out of 10 is the upper limit of what I call the green zone, right? 4 to sort of 6 is the orange zone, and 6 to 10 is the red zone. So a pain of 10 out of 10, when you run, obviously that's a red light, stop, don't do that, that's not helpful, okay? A pain of 5 or 6 out of 10, proceed with caution. We're definitely getting in the realm of too much pain. Up to a 4 out of 10, green light, pretty much keep going. So that's the kind of spectrum I use. And I often err a little bit on the side of caution. So I would say, a pain of 5 out of 10 is kind of okay, but 6 is not. So there's somewhere in the top of that orange zone where I'm unhappy. And some of the ways that we can help decide if the pain is a little bit too high up the orange zone would be, is it settling quickly afterwards? So if you go for a run and you get a pain in the orange zone in your shins, and then you stop at the end and the pain sticks around for like 2 hours, then that's a bad sign. If the pain pretty much goes away as soon as you stop, like within 20 minutes or so, that's a good sign. So the second rule would be pain that resolves quickly once you take the load off, i.e. once you stop running. So that'll be the second rule. We want it to be no worse the following morning. So if you go for a run and wake up and you feel okay, and it's only like an orange light kind of pain, but then you get up in the morning and you're limping around first thing in the morning, I'd say that is actually a red light and you did too much. So you're not ready to do the amount that you did the previous day. You need to pull back a little bit. I would also avoid running 2 days in a row. We're going to talk a little bit about how shin splints develop, so one of the theories, and giving the bone a day off in between, giving it that sort of 48-hour rest period to respond and adapt, is one way in which you can get more running done over the course of a week without piling on a stress reaction on an already stressed bone. So if you put the stress on the bone and let's say you go for a run and you put the stress on the bone, and then the bone is sort of stressed out, and then for the next sort of 24 to 48 hours, the body is responding and repairing the damage that you did. And then by the time you wait 48 hours, that's all finished, you go for your next run and hit it again. Then you wait 48 hours, during that time it recovers, then you can hit it again. Now, if you only wait 24 hours, what you might find is that the healing response or the regenerative response is only about half done, right? So then you pile on another stress response equal to the first one on top of that 50% stress response that you've already accumulated. Now you've got up to 150% stress response. I don't know if I'm explaining that super clearly, but what you get is this kind of accumulating stress response as opposed to a up, then all the way back down to baseline, then up, all the way back down to baseline. What advice would you have for him in terms of dealing with shin splints from running? Now, that's a tricky one because there really isn't any evidence to guide us in any significant way. Now, there's a lot of evidence on the pathology, on what happens, on studying some of the risk factors for shin splints and this kind of thing. So there's lots of stuff to read. However, if you want studies that tell you if you do this intervention, you'll get better quicker than if you do this intervention, or if you don't do anything, there really isn't anything that I can find. I haven't read every single research paper on shin splints, but you know, every few years I come back to the sort of typical running injuries and go through the research and see what I can find. So I did shin splints over the last few days again, looking for recent research in that area. And if anybody knows of any that shows a significant interventional effect of, a significant rehabilitative effect of any specific intervention, please let me know, but I can't find anything. So we're really left with, clinical reasoning, which is take the pathology or what we understand the pathology to be and then come up with a clinically reasonable approach, because we don't know if, putting orthotics in helps or not. We don't know if changing running technique helps or not. We don't know if strength training helps or not, right? We know some of those things are risk factors, or some people have problems with those things and have shin splints, but we don't know that fixing those things fixes shin splints. That being said, I see people with shin splints all the time in the clinic, and I try and help them as best I can. And I'll talk a little bit about that, but it's basically from a clinically reasoned approach. It's not from we've got some super awesome evidence that says that shockwave is awesome for shin splints. We don't, right? It's a reasonable thing to try, but we don't know exactly if it works or not. And we know that the natural history of shin splints is pretty good. In fact, it's pretty good for most running injuries, a few exceptions. But after a year, people with shin splints, even if they do nothing right, they usually don't have shin splints anymore unless they completely give up running. And then they often don't have shin splints because they're not running anymore. So the natural history is quite good. And that can make research more tricky because we know people with shin splints typically get better as the months pass anyway, and just through their own behaviors, through the body's natural adaptive responses. So these are some things that I often do, and for right or wrong, you can give them a go. I would say try things. If you find them helpful, you see an improvement in the pain response, less pain, run further, doesn't hurt as long afterwards, then it's a reasonable thing to continue doing. But if you don't see that kind of response, then it may not be that helpful and may not be that important for you. So some of the things with shin splints, what I look at, running technique modification. So this is because if you go and see, a lot of health professionals about shin splints, what you'll get told is it's an overuse injury, which is true, and it needs rest, which is also true, and then go away and rest. That's not quite true in the sense that it's incomplete. So what we need is relative rest, and resting is a very tricky thing to do well. So if we say, okay, I'm getting shin splints when I run, like how much? How long do you run to get shin splints? Do you get it straight away? Does it keep Does it remain painful afterwards for a long time? Does it happen only when you run faster? Does it happen only when you run slower? Does it happen when you run on certain surfaces or uphill or downhill? Does it happen more in certain shoes? Do other shoes make it happen less, right? So, okay, then we're looking at what are the factors involved in making the shin splints worse or better. So we want to look at that. And then we want to look at trying to find the adaptive zone, right? The name of the show. Not too much stress, not too little. Because if we go to complete rest and you just take 2 weeks off running, what you'll find is that your shins stop hurting, but then when you go and run again, say it comes on after 5K, you run 5K again, maybe you can get to 5.2K and then it starts hurting. So your body really hasn't adapted because you haven't put any stress on it. Now say you just ran 5K every day and every day it felt a bit worse than the day before. 2 weeks down the line, you won't be able to run 1K because you're just making it more and more sore. The adaptive zone is in between. It's trying to find the amount of stress that your tibia or calf muscles can tolerate without irritating them. And that's the whole idea with running rehabilitation, really. So trying to figure out where your adaptive zone is the main objective of the treatment. So one of the ways that we can approach that is to say, okay, well, when you're running, you're putting a certain amount of stress on your shin each step. Now, if we reduce the stress on the shin, potentially by moving the stress elsewhere in the limb, or by making that stress a little bit less each step so that it's distributed over more steps per hour, for example, then we might reduce the stress on the shin to a level that it can adapt to, i.e. the adaptive zone. And then you can get to 6 or 7K before the shin start to hurt. And then that becomes your adaptive zone where you're training. So one thing I would suggest, and I always do this with any injured runner for pretty much anything, is taking walk breaks every 5 minutes or 8 minutes or 10 minutes or 2 minutes. 1 minute walk breaks really help give the shins just time to recover so the stress isn't building and building and building. So I would definitely advocate for, when you're running, putting walk breaks in at a certain interval. You can play around with different intervals and see what works. But a 1 minute walk break usually works just fine. I often change running technique. There's no evidence that this is a particularly helpful intervention. It seems to work in the clinic because you get an immediate change. You change the running technique and they say either my shins feel better or my shins feel worse. So that's quite helpful in terms of guiding the treatment. That doesn't mean that necessarily is an evidence-based approach, but it's an evidence-informed approach and it's clinically reasonable. So I would say running technique modification is an okay thing to try. So the first thing I'd do with people usually is increase their cadence, because if they're, say they're taking, rough guess, like 3,000 steps an hour, and the body weight is remaining pretty much the same during that time, then the amount of stress on the tibia is X amount per step. Now, if we increase that to 3,500 steps by increasing their steps per minute, then it's going to be a little bit less stress over the hour each step. Same amount of stress in the end, but it's distributed among more steps. So sometimes that can make the difference between being able to do, say, 5K and 7K. So I would look at increasing cadence, especially if cadence was low. Sorry, cadence is steps per minute. So you would use a metronome or something like that. I'll put a link in the show notes to many articles I've written about how to do that. But measure your cadence, look at your watch, just time, count how many steps you do in 10 seconds and multiply it by 6. There's different ways. And then if you're sort of falling in that sort of unhappy zone, I call it, where it's like 150 to 170 beats, steps per minute, that's kind of a bit low. You might want to bump that up by 10 or 15% and see, does it feel better? Does it feel worse? Right? If it feels worse, it's not helpful. And that does happen sometimes. Sometimes when you increase the cadence, you change the foot strike. And if you change the foot strike and the issue is more related to the muscles and the connective tissues, and say you went from more heel strike to a midfoot strike, that's going to increase the stress on the calf and reduce the stress on the knee, and that may potentially make the pain worse. So if you increase your cadence and it feels worse, don't do that. That's very important. If you increase your cadence and it makes you feel better, great. So another thing we look at is reducing impact. So if we are each step when we land, the stress that the tibia experiences depending on how hard we hit the ground. So if we hit the ground more softly each time, potentially we could reduce the stress experienced by the tibia and the associated muscles each time, and potentially bring that stress down into the adaptive zone. So I would look at reducing impact, and there's different ways of doing that, but essentially if you run on a treadmill and you're making a lot of noise, you're trying to adopt ways of running that are more quiet. I'll link in the show notes again to some different articles I've written on how to do that, but that's the underlying premise. Now, a couple of things that I played with recently with a client who was experiencing shin pain is we looked at altering the foot strike and the vertical oscillation. So this particular guy was going up and down quite a bit. Now, I'm not sure that there's much research out there on an optimum amount of vertical oscillation, so up and down movement. That being said, his just looked a bit big. So we thought, well, if we don't jump up quite so high each time, potentially we're going to reduce the stress experienced by the tibia and the associated muscles. So perhaps that'll be less stress on those muscles and reduce the shin splints. So that was one hypothesis. And then the other was that his foot strike, he was actually a forefoot striker naturally, which was pretty cool. And it made him, he looked very good as he was running, but he was jumping up very high and then coming down kind of on his toes each time. And I've put a video of this sort of before and after in the description. So what we did is we switched him by reducing his vertical oscillation. We tried a few cues and found one that stopped him going up and down so high. And then instead of coming down landing on his forefoot and his toes, we managed to make him land a little bit more on his midfoot. And I was a bit nervous about this because I thought maybe that's going to actually increase the impact experienced by the tibia, because you're losing that sort of cushioning effect of the forefoot coming down first. Now, that didn't turn out to be the case. For better or worse, we did this intervention and changed his running technique with some others, and his pain got quite a bit better. So we can presume, or we can deduce, that potentially that was a helpful intervention, but it's not the only thing we did. So we don't know for certain because we did some other stuff as well. We almost never just do one intervention like running technique modification. So there are some options in terms of running technique modification, but what I say is that it's a suck it and see approach. So you might alter foot strike, you might alter vertical oscillation, you might alter steps per minute, you might alter impact. There's a bunch of things you could change about the way you run. You might alter the shoes. You might alter you might put inserts in the shoes like orthotics. So there's a few different things you can do in terms of the running technique in order to try and reduce the stress experienced by the tibia and bring it down a little bit so it's more in the adaptive zone of the shin. And then the last bit, just to sort of rehash the pathology, like when we are putting stress on this is the bone stress injury hypothesis or explanation for shin splints would be, when we put stress on the tibia, we cause some damage through that stress, through the bowing effect that we talked about earlier. And then we get these cells that come out to clean up the damage. We call these osteoclasts. And they clean up the damaged bone, and then you get that sort of inflammatory response in the periosteum. That's the outer layer of the bone. And then over the next sort of however long, it might be a few days, it might be a few weeks, those cells are cleaning up, and then some other cells come in called osteoblasts, and they repair the bone, and they've been talking to the osteoclasts who are saying there was a lot of damage, and the osteoblasts think, well, I'm going to take some extra protein and calcium and stuff, and I'm going to make these bones harder, and I'm going to make it so they can tolerate more stress. Now, the problem is with shin splints, when you get into running after some time off, or you're just getting into running at first, because there's quite a lot of damage, so the osteoclasts have a lot of cleanup to do, the osteoblasts can't keep up. So you go out the next day, run again, you've created more damage for the osteoclasts to clean up, but they weren't finished with the previous days. The osteoblasts are like, well, you're not finished cleaning up, right? And then the next day you go and do it again. So the sort of damage side of the seesaw is too high. And what we want to do is give it some more time off between each impact experience between each run to give those osteoclasts time to clean up and the osteoblasts time to make the bone stronger. So I think that 48 hours, but it might have to be longer, right? It might be 72 or something like that. A little bit longer. Make sure that there's not too much damage caused, right? So don't, if your threshold or your adaptive zone at the minute is somewhere around 5K with some walk runs, don't go up to 7, right? So stay within the tolerance zone of the shin. And as the osteoblasts produce stronger bone that can tolerate more stress, you go with it. So after a couple of weeks of doing that, you might find you can do 6 or 7K run walk, and then that's your adaptive zone. So don't go back down. That's where the advice of just rest, it's an overuse injury, kind of doesn't work. Like I say, it's right, but it's incomplete, because if you just rest, you wouldn't go up to the 6 or 7K once your shins were ready. And that's essential. If you want to get over it, you've got to go up to that zone, because if you stay at 5, your bones and your muscles will be stress tolerant to about 5K. They won't reach a tolerance for 10K or 25. And we know this intuitively, but what we often do with shin splints is we try and rest them better, and you can't rest things better. You have to put stress on them. You just have to find that adaptive zone. You have to find the point where you're putting not too much stress, but not too little either. The last thing I always do with everyone, pretty much, is make the area stronger. You can't go wrong getting strong. Essentially, that's from a physiotherapist named Adam Meekins, who you can look up. He's great. But yeah, you can't go wrong getting strong. If you make the muscles, the tibialis anterior, the tibialis posterior, the soleus, the gastrocnemius, some of the long toe flexors, even the knee muscles like the quads and the hamstrings, if you make them stronger, they will be able to help absorb the stress of running. They will be able to help you deal with the impact. And that's why you can't go wrong getting strong. So I would suggest seated calf raises, straight leg calf raises, one leg calf raises, right? Calf raises is a pretty boring exercise, but also like strengthen the upper part of the leg, do lunges and squats and go heavy. So I would say getting the feet and the calves stronger is a good strategy, because they can help you handle that stress. And in the description, I've put a little bit, some videos that I've posted online of just me demoing these exercises, just so you know what they look like. And I think that's pretty much everything. So that's shin splints. In summary, you've got to find the adaptive zone. That's always the way to go. You've got to not over rest it. You've got to make sure that you're doing the amount that your shins can tolerate and not more. You're going to try taking walk breaks. You're going to try changing your running technique. You're going to try making your legs stronger with strength exercises. You're going to try taking 48 hours off between rests. And before you do any of that, you're going to go and see a qualified professional, because you want to make sure it's not a stress fracture. If it was a stress fracture, it's the same approach. You're just going to expect that it's going to need more time off between runs. It's not going to be able to run as long. It's going to take longer to resolve. It might take several months instead of a few weeks to resolve. And you are going to expect that regardless, you're in it kind of for the medium term. So think, okay, I'm going to be handling this for the next 3, 6, 9, 12 months. Because if you're expecting it to be better in 3 weeks and then it's not, you're going to stop doing all these things that were potentially the correct things to do. And I think I'll sign off there. All right, guys, see you next week.